Okay, guys, this is Mike and Tom back again for another documentation orientation module. And just as a reminder, this is a series of short modules that are used to,
sometimes not so short,
some less short than others, to share tips and tricks to make your documentation better for this particular one. But in general, it's to talk about how we like to document here at EPT and the kind of things that we want in your chart and why, hopefully. Primary target would be people new to our practice, physicians and mid-levels, and even our residents, but it's also a pretty good review for any of our established providers. And we're trying to keep these relatively short. Some of them have gone a little bit longer because there's a lot to talk about, but we'll try to do our best.
So last time we talked about the diagnosis, and just a quick review here. You don't need to know the diagnosis, but your chart needs to support whatever your conclusion was. So if you use abdominal pain, other, or whatever, you can do that if you're not sure what the diagnosis is. Remember that your diagnosis does communicate your thinking. It's one of the first things that any consultant or primary care physician looks at. It does not drive revenue, but it does sometimes trigger a downgrade or a downcode.
Right.
And now let's move on to what we like to call the art of the chart. So we've talked about a lot of these things in our previous modules, but I think putting them all together in one area now will be helpful for you. So first thing is that we like to keep the charts concise and keep them focused on what the problem is. And so we like you to only include things that we think are pertinent to the situation.
You don't have to be wordy, and I have to confess that I'm probably wordier than I need to be in my charts, but I do that in my speaking as well.
And you did that when we used to handwrite charts.
Yes.
So that's just the way you are. And some of you are going to be wordier than others.
But I've really tried to make an effort to try to use less words to convey the same idea, but basically just to communicate the story of what happened to the patient while they're in the emergency department, because ultimately that's what the chart is. But if you think about it, when you review records and other people's discharge summaries or HPIs or whatever, you don't really want a lot of extraneous information. You just want a quick, okay, here's the diagnosis, here's what happened while the patient was there. Here are the pertinence. We don't need to regurgitate every little thing that's also in the chart. So, and then really I'm talking about medical decision making, because that's where most of the narrative is.
Right. And I would say HPI also. I mean, if you've got somebody who's come in with an ankle sprain, you don't need to put in their HPI that they had a cholecystectomy a year
even
ago.
Though they told you and they thought it was very important.
Yeah, and that's the thing, I think, and this is something I think that our scribes, as they get experience, pick up pretty well. I've been impressed. But patients will sometimes go off on these long tangents about it has nothing to do with anything. And when I'm talking to them, I try not to interrupt them, because I want them to feel like I'm listening to them and not being short. But none of that stuff needs to go in the chart.
Exactly. You got to be a filter.
Yeah. It's also important, I think, when you talk about documentation, the pertinent information we want in the chart. Some folks will get hung up on which section do I put it in. Does this go in the review system or does it go in the HPI? My answer is I don't care. I just want it in there somewhere. You can put it in medical decision making if you want. As long as the coder and any reviewer can find that information, it doesn't really matter to me where it is exactly.
No question about it. And for example, if somebody comes in with, say, an ankle sprain, and you type in your HPI that they've got no distal numbness or tingling, that they can bear weight, what type of injury it was, that they have no other injuries, you don't even need a review of systems. There's nothing, you can leave the review of systems blank. You've got everything you need in the HPI.
Right, because a good coder will pick that up
and
identify that as review of systems. We don't want you to repeat information, and I see a lot of our younger providers, our residents when they first start, our PAs when they first start, oftentimes they'll create these beautiful HPIs, these beautiful physical exams, and then they'll get to their medical decision making and they'll repeat almost all of it verbatim. And that really doesn't need to be repeated. You can summarize if you want to. I think that's fine. But you really don't want to repeat information that's already in the chart somewhere else.
Exactly.
If you can. Now, sometimes I'll, say somebody comes in with abdominal pain, and I'm, I know that it's not their gallbladder because they had their gallbladder out a year ago. Well, I might mention that in the medical decision making as a reason why I'm not worried about their gallbladder,
right,
even though it's in their past surgical history. So things like that I think are okay. but you don't want to go through the physical exam. You don't want to go through the
Yeah, I
HPI
mean, you could
yet.
put, CT reassuring, will discharge him,
Yeah.
repeat, recheck in 12 hours for someone that you're worried about, say, appendicitis. But you don't, again, you can put little pieces of information there, but you don't need to put the whole report or anything.
Absolutely. And then we've hit on this a few times in our other modules, but we really want to hammer home the idea that the length of your chart and the complexity of your chart should reflect what happened in the encounter and the complexity of that encounter. So if you have somebody with a fairly simple dermatitis type rash, you don't need 2 or 3 paragraphs in medical decision making. Conversely, if you have somebody with a CVA and there's a lot of consideration, or you spend quite a bit of time considering whether to give them TPA or not, that's going to require probably 2 or 3 paragraphs.
Absolutely, and it may be, or a bunch of time progress notes to discuss,
Right.
what's going on
Yep.
with the patient. I mean, you can have a patient that comes in that looks pretty good, ends up intubated in the ICU, and I've seen charts like this where it's like, what in the heck happened while they were in the ER?
Yeah.
And then you can have that same patient, and you got a time progress note patient in, CHF, pulmonary edema, morphine, nitro, Lasix given. Go back, then there's a dot now recheck, patient getting worse, now put on CPAP, dot now recheck, now intubated.
Yeah.
But the point is that you can go back and look at that chart and go, oh, I see what happened.
Exactly.
They just kept getting worse. They were not improving, and so they ended up intubated or whatever it was.
We've mentioned this, I think, in every single one that we've done so far, but I really want to, again, emphasize, please beware of templates. Templates are nice because they save you time, but there's a lot of bad things that can happen with templates. Number one, they can generate inconsistencies in your chart. Number two, they create a chart that when you look at it can be very difficult to differentiate one patient from another. This is especially true, in my opinion, when you template your HPI and your physical exam. So I'd just be very, very cautious with those. Tom likes to create very simple templates and then tailor them to the individual encounter. We call that documenting up your
Right.
templates, and I think that is a great way to go. And since he taught me that trick, I feel like I've gotten much better in managing my templates. When I look at a chart, if I look at a chart, even a chart that I've done, and I can't remember the patient, I can't recognize the unique aspects of that patient visit, then that tells me the chart is too templated.
Exactly.
And that makes it really, really difficult. I can't speak for the coding because I'm not technically not a coder, but when I review a chart from a QA standpoint, it makes it very, very difficult for me to make heads or tail of
And
what
if you've ever
happened.
done a chart audit where you've looked at multiple charts from the same provider and you see 3 or 4, chest pain patients and every chart looks identical, that's a huge
really,
red flag.
really,
and it calls
really
into
tough.
question really what you're doing. Are you
Yeah.
really asking those questions? Are you really examining that part of the patient?
Yeah.
So
So just be careful with that. If you've documented a patient and then at the end of the shift you go back to review the chart and that chart doesn't tell you anything or doesn't trigger any memory about the patient, then you're using too many templates and you need to stop doing that.
right.
So to wrap up, only include the pertinent information. Don't repeat information. I feel like I should say that twice.
Tell
length
the
of chart-
story.
The length of the chart should reflect the complexity of the encounter. And once again, please, please, please beware of templates. So next time we are going to talk about some things to avoid, some things that we don't want you to do. I think that will be hopefully very useful.
Absolutely.
And as always, if you guys have questions or comments or concerns, please drop us a line, and we look forward to the next module.